disclosures as I begin to report. No financial arrangements, no financial disclosures regarding the contents of this activity. And yeah, we're talking about sort of how do we best utilize a team-based approach when we talk about treating patients with buprenorphine. And so, of course, we're going to start out by talking about the importance of using a team-based approach. Then we'll go into kind of different components. Who might be the different components of a medications for opioid use disorder team that might be able to, and what their responsibilities might be. A little bit about the administration. How can administration support building a team? Because admin support in real life becomes very important, right, for the team to come together and to be able to function. Yeah, so that's really what we're gonna go through. So I think really this slide sort of says it. Why use a team-based approach? Well, it's really to leverage resources, which for many of us are quite limited, right? I think certainly in many of the communities around New Mexico, even here, right, there are a clinic at the University of New Mexico, the resources can be limited. And historically, recently, with the new legislation passing SAMHSA, prescribing of buprenorphine has sort of become much more universal, right? Where any prescriber with a DEA registration should get trained in prescribing buprenorphine and can prescribe it. Gone are the patient limits, gone are the X waivers. But still, in real life, we haven't yet seen a big increase in the number of people who are getting treatment with buprenorphine for their opioid use disorder. And historically, the prescribers have been a very limited resources, right? I think there was a classic study back in 2016 or 2015 that showed that only about 3% of US physicians actually held their waiver to prescribe buprenorphine. So especially in light of these raging opioid epidemics, rising overdose mortalities, the treatment availability hasn't kept pace. And if you look at the literature, looking at the barriers to why buprenorphine is not more widely available, of course, resources, there are many forms rise to the top. So I think that's really the reason why we think about using a team-based approach, because then people can support each other, work together, and hopefully that leads to more access to evidence-based care, right? So a little note on treatment teams here as we go through this. And the bulk of the evidence, when we talk about substance use disorders, especially within the context of co-occurring psychiatric illnesses, support the idea that integrated treatment improves outcomes, right? Gone are the days, and although it happens a lot, gone are the days and really discourage people from doing sort of this serial treatment where people may get treated, for example, for their post-traumatic stress disorder first, and then they come into treatment for their substance use disorder. We know that doing that, providing treatment in parallel, right? So for example, if I saw someone this morning who had both post-traumatic stress disorder along with opioid use disorder. So we really think about treating them together in that integrated parallel manner, improves outcomes for both. And that really is considered the gold standard, as the slide points out, by nearly all regulatory and research bodies, and improves outcomes. And then a little note, we often use these words interchangeably, multidisciplinary and interdisciplinary, but there's a little bit of a difference, right? Multidisciplinary treatment team can be a bunch of people who are working at the same time, but not necessarily in a coordinated manner. So for example, maybe I have a patient who sees Dr. Plum for their PTSD, and they see Dr. Warwick for their opioid use disorder treatment, but Dr. Plum and Dr. Warwick aren't necessarily talking and coordinating efforts, right? It's clearly multidisciplinary, but it's not interdisciplinary. In an interdisciplinary treatment model, Dr. Plum and Dr. Warwick in that example would be actively talking to each other, coordinating care to really align their efforts. And that really is considered the gold standard, right? Ideally, treatment should not just be multidisciplinary, but interdisciplinary. So that's the other note here, without reading every line, of the slide. So some concepts. So recovery, right? The concept of recovery, I think we do a number of other talks that reference this, that go into this in more detail. But few things I will point out because they're important. Recovery is defined by SAMHSA, where hope for the future is really at the cornerstone, at the center of the recovery process. Recovery variously has been called by people as reclaiming one's life, as you improve and as you heal, of achieving that potential, for example, and hope is at the center of it. And other aspects of recovery can include health, both physical, psychological, as well as, I would say, spiritual health, right? For many people can be very important. I would also, other components of recovery can include stable, safe place to live, having a meaning, finding meaning in your life, in the work you do, in the connections you have, and those meaningful, supportive social networks can all be a part of recovery. And some of the data over the years, including some recent studies, have pointed out that the amount of people in the United States who consider themselves to be part, in recovery is actually pretty high. It can be up to 10% of the US adult population. So many people are in recovery. People do recover. We often just don't hear those stories, right? So I think there's a lot to be said about recovery, but it really, as this point out, it's more than just remission in symptoms. It's more than just stopping substance use. It's really finding new meaning and purpose in one's life. And they can often go together. There might be overlaps between substance use and recovery, but they're not exactly the same, right? They're parts that can differ. And really, to sort of, when we think about kind of the treatment team, a recovery-oriented treatment team, certainly patient is at the center of it. I had a patient once tell me that, I've been told and I understand that I'm the captain of the ship and you guys are all supporting me, and I love that idea. And I told the patient at that time, this was like 2 years ago, and I said, I'm going to use this example. Is that okay? And the patient said, sure, do it. So I'm doing it here right now. And that's actually the truth, right? Where the patient really is at the center of the treatment team, but then other people are around the patient to hopefully support the patient in their journey and improve outcomes. And if the patient, and the importance of that is, again, the patient is the captain. If they don't buy into the treatment plan, we can come up with all these great evidence-based things, but if the patient doesn't buy into it, if it doesn't pertain to their life, it doesn't relate to their life, it's a lost opportunity, right? It's not really going to work. There's this concept that slide sort of reminds me of this concept that exists in literature called, practice-based evidence, right? We often talk about EBPs, or evidence-based practice, where we apply the evidence that exists to practice. But then there's this concept of practice-based evidence, which is the information we glean from practicing, from working with patients. And how can we bring that back to the global evidence that exists and hopefully create more individualized treatment plans? So that sort of reminds me of that. And we really got to have an infrastructure in place where the team can come together, learn from each other, work together, and improve outcomes. And kind of going forward here. So what are the components of a treatment team? And I think I looked at this a little bit earlier, these slides this morning, and some of it has changed in light of the recent legislation, and I think for the better. So I will point that out when we get to that. So team structure, right? The core team, of course, includes the patient, the client, and the primary treating providers who work with the client. But then the extended team will bring in other components depending on the needs of the client, including significant others, including other providers at other agencies, etc. So in terms of structuring the team, we need client buy-in, as we pointed out, and ideally it really helps to have a team lead or the manager who sort of guides and coordinates all the efforts. And this person is often the primary person working with the client, right? A coordinator or a recovery coach who can help organize team meetings, communication can also be very important. And other, I think it really helps where people have a defined role, people in a treatment team where you know what the role is, but they're flexible enough to step into other roles as necessary, right? So I think one example I can think of, right, I'm here sitting at ASAP, and so is Dr. Jacobson this morning, and our role is kind of as the prescriber, right? That's our defined role. That's the role we're playing. But working with others in the team, we're going to be flexible enough where if the client needs help, for example, with housing, or they're having an acute crisis and they need to talk to someone, we can sort of be flexible and meet those needs. And I think a big part of this is the team cohesion, right? As long as members of the team respect each other's and the role each other, everyone plays, understand at least the basics of it, I think achieving this becomes a lot simpler. So now let's go into some of these roles in more detail. The team lead or the program manager can be really any independently licensed provider, including a nurse, a MD, a therapist. Historically, I will point out that nurses, RNs, have often been used in this capacity. And I think that's largely because of billing, the way billing works, where oftentimes RNs have more flexibility to step into this role. Certainly in some of the larger organizations, including here at UNM. So it's often RNs are utilized in this capacity, but it really can be anyone who's independently licensed and who understands the illness and the recovery process. This person becomes the consistent point of contact for patients, right? They're sort of the team lead. They're managing the entire treatment. They're playing a role in coordinating between all the team members, between the team and the patient. May have some patient care functions, as you'll see, right? And may conduct support or education groups through the program. Recovery coach, I think there is a big role for people in recovery, right? To step into this role, often as engagement specialists, peer support specialists, but oftentimes in other models, other team-based models, people have also used medical assistants, RNs, or CHWs in this role as well, kind of a patient engagement role, and does require some training to step into this role. And the goal really is, how do we keep the patient engaged? For example, here at ASAP, we have a patient engagement team, which is, people from multiple disciplines. And when the patients are early in treatment, particularly, if they don't have a stable point of contact with a therapist or with a physician, they're reaching out to the patients, checking in. Are you safe? Are you okay? Do you need to come in? Can we help arrange transportation? What are your needs? Do you need us to work on a letter for your PO, for example, to kind of meet those basic needs of the patient to facilitate engagement in treatment? Right. And some of the other duties, important roles that this person can play is things like prior authorizations, which many of the prescribers will attest to, right? That it can take up, unfortunately, a lot of time and a lot of effort, checking the prescription monitoring profile, those things that facilitate the prescribing, maintaining buprenorphine logs, can do some simple, again, with training, clinical duties like vital signs, pill counts, urine drug screens. So they really become an integral part of this team, right? Let's see. Patient education. And I think this is often where recovery coaches, people, peer support specialists shine, where they can bring in their own lived experience into this process. And over the years in various places, I've seen some amazing examples of the role that the peer support specialist can play. One that often comes to my mind is, this is several years ago, where we were doing a project with a sort of it was an IHS clinic up in Northwest in the state of Washington. And they had just started doing kind of home buprenorphine initiations on patients with opioid use disorder. And they would pair up any patient who was going through the process with one of their peer support specialists, who would check in with the patient, say, hey, you're doing great. How can I support you? Don't start the medicine yet. It's too soon, but I'm here in case you need the support. And I think that was working really well for them. And that was something they decided, right? Practice-based evidence. They decided at the community level that would be something that would be really good for them. And they implemented it. And I wish they would publish it, because I think it's such a cool program, but it's working for them. So that's great, right? And providing psychosocial support. And then we can again bring in other things as needed, as important to the patient as resonates with the patient. This can include things like 12-step programs, right? Many of our patients at ASAP find smart recovery really resonates with them. Traditional healers, inpatient treatment programs, right? Residential communities, crisis line. So all these things, harm reduction sites, including syringe exchange, overdose prevention, right? Naloxone distribution. I would add fentanyl test strips. So other things as needed for the patients, we can bring in HIV and hepatitis testing, those really real life, those basic needs without which nothing else can happen, like safe place to live and food and housing, right? Emergency housing. So all of these things, employment, psychiatric and medical treatment, as you can see, all components of recovery, right? That we hopefully provide and support our patients with. Therapy, right? I think psychotherapy, many of our patients have co-occurring illnesses, right? I think at ASAP, over 2/3 of our patients, I think, have post-traumatic stress disorder, not just a history of trauma, but actual PTSD. I think, again, nationwide, if you look at data from SAMHSA, 40 to 50% of patients with substance use disorders have a current co-occurring psychiatric illness. And I think psychotherapy can be really beneficial. And so one thing I would point out is one size does not fit all. So I tend to recommend against having just a standard quote unquote psychotherapy that every patient fits into, but really seeing what the patient's needs are and matching it to an evidence-based psychotherapy can really improve outcomes. And these are just some of the ones listed here, again, depending upon what the patient's needs are. And if there's a in-house behavioral health team, amazing, right? I think we're certainly fortunate enough to have that here. But if not, sort of really forming those relationships with other providers in the community to have a warm handoff can help. Pharmacists, right? I think we probably have on any given echo, we have at least a couple of pharmacists on and play a crucial role in sort of at a patient level, I think, but also at a community level, I have found. Right, in terms of there's so much literature coming out about what the pharmacist's role is within the opioid epidemic, and are often sort of the first line who pick up concerning things that they may see, such as sedation, etc. And there are also now data coming out, papers coming out, projects showing what's the best way for a pharmacist to engage a patient in a discussion around safe prescribing practices. So certainly lots of roles for a pharmacist, including but not limited to naloxone distribution and patient education. Physician education, right? We included here on chronic pain management practices. I think I certainly benefit from learning from our pharmacy colleagues. And I think a lot of the newer literature has really been focusing on identifying high-risk patients and engaging them towards safe prescribing practices. Advanced practice nurses and physician assistants, at this point, and data has shown that this has really improved outcomes in terms of access to care, when we talk about the opioid epidemic, can prescribe, right? Just like physicians can when it comes to buprenorphine, that initially changed under the CARA, the Comprehensive Addiction and Recovery Act. I'm horrible with acronyms, so someone can correct me, but I think that's the one that rolled off my tongue. But now certainly with the new regulations, as within the state laws, which can change from state to state, are certainly free and to prescribe MOED. There was a study about 4 years ago, that showed that ever since CARA was passed, prescribing of buprenorphine went up about 20 to 25%. And so it's made a huge public health impact. I think, again, physicians' roles are going to be very similar to our physician assistants, APNs. I think in many of these treatment models, collaborative care models, one kind of unique role that physician has often played, the physician buprenorphine prescriber, has been the role of education for the whole team, right? Kind of doing regular educations to kind of make sure everyone is following evidence-based practices, prescribing to the standard of care. And that's often been the unique role that the physician has played. And this is a reference slide. I won't go into it in the interest of time. That looks at all the different things. I mean, it's a lot of things that we talk about in this echo, right? All the different training aspects and who should be trained. I think for a lot of it, you can see it's all staff, right? Understanding basics of addictions, managing challenging behaviors, setting appropriate boundaries. I think a lot of this starts at the front desk, who often are the first people to have that interaction with the patient and can set the tone, start establishing that rapport, helping the patient feel comfortable, etc. And then we'll end with a little note on the Massachusetts collaborative care model, which was one of the first models that was studied, kind of a team-based model for treatment of patients with opioid use disorders. Now there are many other models out there, but this was sort of the first one, and so we often like to use it as an example because they had some impressive data. and this was in the state of Massachusetts. And once they rolled it out, they were actually improved significantly. The number of people at that point, it was physicians only under the law prescribing buprenorphine, and they were actually able to dramatically increase access to patients. So it really was successful. And again, they use that nurse, the nurse care manager, as the center, right? And you can see here all of these other components of the team that they brought in as needed. And what they found was that financially within their model, and again, it differs from clinic to clinic, so I don't think this blindly applies to everyone, but within their model in Massachusetts, combining one nurse with one MA, they were able to successfully treat up to 125 patients with that group, because the physicians at that point were so limited. So how did they do it? They found it was viable and sustainable. This was the flow chart, where you can see a lot of this was done by the nurse care manager who did the initial assessment. It was all scripted, it was standardized. And then the whole team would meet, they would do a chart review, and then they would get the patient into treatment as soon as possible. And again, at that point, the prescribers were few and far between, right? This is many, many years ago. So their role was kind of limited to prescribing. And you can see, I mean, this is always flabbergasts me that the prescription was generated by the nurse care manager, and the MD just came in and signed it. so that was kind of always makes me chuckle a little bit, where I think, I don't know, they really erred on that side. And then again, this was all standardized. So the patient would start buprenorphine, the nurse care manager would support them, troubleshoot with them, keep in contact with them, and also did the follow-up visits with the MD providing backup. And the other big thing that the MD did was do the trainings, right? And waiver training, but also kind of basics, addictions 101, buprenorphine 101, training, shadowing, all of those things, right? Just to build up the knowledge, democratize that knowledge, and providing tele or email backup to support other members, especially as they're going, can be really helpful. And the other trainings included things like billing support, helping create policies and procedures, all of those important things, right? And that's an example of it. And I finally end with a plea. I don't know if there are any administrators there, but the data is clear that administrative support can make or break medications for opioid use disorder programs, and often comes up in literature as such. So I think, just a plea that I think this is a treatment that saves lives. Right? Lots of data that buprenorphine treatment for opioid use disorder significantly reduces, just using one data point, all-cause mortality, overdose mortality, as well as suicide-related mortality in patients with opioid use disorder who may also be depressed, right? So it's a life-saving treatment. So it's imperative to support the clinical team, right? By allowing for those regular meetings, open communication to really create team cohesion. I think that's a big piece, and important. Coverage issues, appropriate staffing, so people aren't getting burned out, so people are getting the quality of care they need, allowing time for training, continuing education to continue to build up that expertise, creating procedures, clinic policies that are collaborative, patient-centered, and I would say anti-stigma, right, are all important. So I think, and I'll kind of end here, that I think for all of us, being an advocate for our patients, right, is important. Again, creating that patient-centered anti-stigma environment, supporting policies that ultimately benefit our patients. So I'll stop here